Started here. Okay, so the recording started. Welcome everybody. So today we're going to be going over skin integrity and stress practice questions. This is going to be on the final exam. So yeah, let's go ahead and get started. So the first question, we have place the phases of wound healing in the correct order. So the three phases are maturation, proliferative, and inflammatory. So for this one, the answer is going to be, so the first stage is the inflammatory stage. The second stage is the proliferative phase. And then the third stage is going to be the maturation phase. So during the inflammatory stage, you have that hemostasis, which is where that blood clot is going to form. And this is also kind of with the inflammation. So that's where you're going to see the redness, the tenderness, the heat, the swelling. And that's where a scab will eventually form. And then during the proliferative phase, which is the second phase, that's when the granulation tissue is going to develop. That's that red beefy tissue that we see when a scab or something's healing. And then the last stage is going to be maturation. And this is when the epidermis is like able to heal from that granulation tissue. So a good way I like to remember this is like inflammatory is always going to be first. And then maturation, I like to think like when you're mature, you're the oldest, so that's going to be kind of like the last step. And then proliferative, that's like, I like to think proliferate, like things are growing and getting bigger. So that's kind of with that granulation tissue, like all of the cells are like making more cells so that they can heal that wound. So our next question, the nurse is educating a client with new onset type 1 diabetes regarding microvascular and macrovascular complications. Which intervention should the nurse instruct the client to include in daily care related to skin? Select all that apply. A, inspect the feet daily. B, soak the feet every day. C, dry the feet thoroughly. D, wear well-fitting shoes. And E, clip the toenails every week. So for this one, so with any diabetes type 1 and type 2, the feet is going to be a really important topic because with the two complications are that microvascular and macrovascular, which you'll learn about in Complex Health 1, but this is having to do with the blood vessels. So in the feet of diabetic clients, they a lot of times lose sensation and have decreased sensation, and they don't realize that they have decreased sensation. So they will jam their feet into a lot of things and not realize and get a lot of wounds on their feet, and that can have a lot of complications because, you know, the blood flow to their feet isn't always the best, especially in like the older patients. So it's really important that we teach diabetic foot care. And you'll learn about this a lot in Complex Health 1 as well. So they need to inspect their feet daily. This is because, like I said, they're not feeling when they're like maybe hitting things with their feet. So have them look at them every day to make sure there's not like a wound that needs to be cleaned. They shouldn't soak their feet every day because that causes them to get that like sogginess that your feet or your hands get when you're in water, and that can lead to maceration, which is like when the skin just kind of sloghs off. And can cause skin breakdown. So we don't want them to soak their feet. We do want them to dry it thoroughly after they get out of like the shower, because this is going to prevent any fungus from getting in those in between the toes, especially. And then D, they need to wear well-fitting shoes. We usually recommend that, or it's usually recommended that they get like specially fitted shoes that are like a few sizes bigger. So you'll learn about that as well, but that's something to know. Not wearing flip-flops is really important. They need to be wearing like sneakers all the time so that their feet can't get injured. And then E, clipping the toenails. This one always caught me off guard in school. And you'll see a lot of patients have toenails and fingernails that really need clipping, but that is always going to be for the podiatrist to do because we just don't know like what could go wrong really. So the podiatrist, especially with the diabetic patients, needs to be clipping their toenails because they don't have that sensation. So you could like cut too much of their toenail off, or, you know, the toenail comes all the way off. So it's going to be A, C, and D for this one. Number 3. So the nurse is working with a client with low total protein and serum albumin levels. The client presents with bilateral pitting lower extremity edema. Which education should the nurse provide to decrease and prevent edema formation? So for this one, you want to pull out those keywords. So we see the client has low total protein and low albumin. So albumin always is going to tell us protein, and it's also going to always have to do with nutrition is our albumin level. And also going to be highly associated with edema, specifically in those lower extremities. So to prevent edema formation, we would want to increase protein foods in the diet. So albumin is that binding protein. So I always just kind of think, it isn't protein itself, but I always kind of think of like albumin and protein as kind of being like one and the same because they're usually kind of correlated. So we want to increase protein foods when the albumin's deficient because fluid is going to leak out of the capillaries into the interstitial space. And that is what causes the edema and the skin breakdown when we don't have enough protein. So anytime you're going to see a low albumin, we always want to increase the protein in the diet. For this one too, increasing fluids during the day, that would be a good intervention for constipation or any kind of like urinary issue. Increasing vitamin C and zinc, that's going to be for wound healing. And then increasing cholesterol, you really want to do that because cholesterol is not the best for us. Number 4, the nurse is assessing the skin of a client and notes the area around the buttocks is reddened and macerated. Which factors may have contributed to this finding? Select all that apply. Fever, nausea, vomiting, urinary incontinence, continuous pressure, and diaphoresis. So maceration is, like I said, kind of when you're having like the skin is almost just like sloughing off, like peeling off. And so what that can be caused by is going to be A, C, and E. So fever, urinary incontinence, and diaphoresis. So with maceration, you always want to think moisture. You could always think M and M. So with maceration, it's always going to have to do with there being too much moisture. So not necessarily going to be a pressure injury, but it is kind of like more of like a shearing. So from fever, fever will produce that excess moisture on the skin. So nausea, vomiting, this one's a little tricky, but it's not really related to the skin. And if they're just having nausea, vomiting, not going to be on the buttocks, especially. Urinary incontinence, definitely. If your patient's sitting in urine, they're getting that moisture on their skin, and their skin is going to get, like I said, just like with those diabetic patients, when they soak in water or you're sitting in water, your skin gets kind of shearable. And then continuous pressure, this would be a big risk factor for pressure ulcers, but not necessarily maceration. And then diaphoresis, again, that's like sweating, so that's going to be moisture as well. So that can lead to maceration. Which phase of wound healing describes collagen fibers breaking down and remodeling? A, hemostasis, B, inflammation, C, granulation, and D, epithelialization. So for this one, the answer is going to be D, epithelialization. So this is going to be where the wound is healing, and so we think epithelium, we think the skin. So this is where the skin is being able to remodel. So this is a really great chart that shows you, so you have your inflammatory phase, then you have that hemostasis and inflammation that occur, like I said, at the same time. Then you go to that proliferative phase where all the new cells are being made, and then we go to that maturation phase, and that is when the epithelialization will occur. So hemostasis, that's when the platelets are aggregating to slow the bleeding, so we know that wouldn't be A. For B, inflammation, this is when those macrophages are going to be coming to the area. You're going to have the release of that histamine and all of the complement factors that are going to kind of come with that. White blood cells are going to migrate, vasodilation, all those things. And then granulation, that's when the fibroblasts are going to come to the wound, and that's where they'll form collagen. So where they're breaking down and remodeling, that is going to be after the granulation. And the granulation occurs during the proliferative phase. Number 6. While assessing a post-op patient, the nurse finds that the patient's wound has separated and part of the bowel is protruding through the incision. The nurse documents this as A. Dehiscence, B. Evisceration, C. Fistula, and D. Hematoma. So this one is going to be evisceration. So if the patient's wound separates and nothing comes out, like in this top picture, that's dehiscence. So the wound has separated from the stitching. Evisceration is when the wound has separated and parts of the internal organs are going to be coming out. Evisceration is way worse, obviously, than dehiscence because, as you can see in this lower picture, that's the bowel coming out. So what happens if that bowel starts to get necrotic, then, or there becomes an obstruction, then we have a lot more complications. So with these patients, we immediately, we'll go over this, what we're going to do, so I guess I won't give it away. But this is a medical emergency. And then with the fistula, this is going to be an abnormal passage that connects two body cavities or a cavity and the skin. So a lot of times fistulas occur in like the genitourinary tract. So a lot of times you'll have like a fistula that is between like the rectum and the bladder, or the rectum and the skin. So that's what a fistula is. It's like a tunneling. And then a hematoma, that's like a blood vessels or like blood sac that's kind of sitting there after, you know, an injury or surgery or something. You can develop like a hematoma, which is just like a big, it's kind of like a bruise, but it like gets really big and swollen and painful. But for this question, it's going to be evisceration. And make sure you guys know dehiscence too, because I know that that's definitely going to be on the exam. So that dehiscence is just the separation. Evisceration, it separates and is going to protrude out. Number 7, the client calls the nurse to their room and states, "Look, my incision is popping open where they did my hip surgery." The nurse notes that the wound edges have separated 1 centimeter at the center and there's straw-colored fluid leaking from one end. The nurse's best action is to A. Notify the surgeon, stat, B. Place a clean sterile 4x4 over the incision and monitor the drainage, C. Wrap an ACE bandage firmly around the area and have the client maintain bed rest, and D. Immediately cover the wound with sterile towels soaked in normal saline and call the surgeon. So for this one, it's going to be B. We want to place a clean, sterile 4x4 over the incision and monitor the drainage. So a 1 centimeter separation of wound edges, that's too small for dehiscence. So that's why we would only go ahead and place like the sterile 4x4 over. Now, if it had actually dehisced, then we would D, immediately cover the wound with sterile towels soaked in normal saline and call the surgeon. That's what we would do if it dehisced or it eviscerated. But for this one, because it's only 1 centimeter, this one is a little tricky. You would just place the sterile 4x4. But if it did dehisce, then you would cover the wound with those sterile towels and call the surgeon. But a big one with this one is if this comes up, what are you going to do? We never call the doctor first, because who knows where the doctor is and what the doctor is doing, and what are they going to do? They're not at the bedside. So the first thing that you want to do in any of these situations is always do something that's going to help prevent any injuries. So it's either B and D are kind of like the best two. And then we would never wrap an ACE bandage around that because that is just not what we would want to do. But you do want them to maintain on bed rest. Which of the following are risk factors that contribute to pressure injury development? Select all that apply. So there's a bunch here, but I like these to kind of like get my brain thinking. So with the select all that apply, we always want to think like true or false. So the options are immobility, pressure, dehydration, daily exercise, impaired sensation, aging, and frequent position changes. So with these, I always think of them as true or false. That's like the best way to do it. And if you don't feel like it's the right answer, for me personally, usually will just not pick that one because with the kind of like partial credit, especially on the NCLEX, that's kind of like the best way that I like to go about it. So for A, immobility. So I like to go through each kind of and say, immobility. Is immobility a risk factor that contributes to pressure injury development? Yes. Then I'll move down to B. Pressure. Is pressure a risk factor for a pressure injury? Yes. So I'll click that one. So going through them all, we have A, B, C, E, and F that are all going to be risk factors. So immobility, pressure, dehydration, impaired sensation, and aging. Impaired sensation is going to be one of the biggest ones. This is technically the most important one that contributes to pressure injury because they don't notice that they're having that intense pressure. If you are able to feel you're a little bit younger, you can kind of be like, oh, I've been sitting on the same spot for a while. It's getting kind of sore and numb. So again, with aging, as people get older, a lot of times they have that impaired sensation, more likely to be immobile. And then immobility obviously is a huge risk factor, not being able to get up and go. And so therefore, daily exercise and position changes, those would be protective against getting a pressure injury. Number 9, the nurse assesses a stage 3 pressure ulcer on the coccyx of a client. The nurse notes the wound bed is pink with pink to red drainage without odor. Which type of drainage would the nurse document in the medical record? So this is a really good example of a question that can kind of throw you off. So we see assessing a stage 3 pressure ulcer on the coccyx. So when we read this question, we're starting to think, okay, maybe is it going to be about this stage 3 pressure ulcer? But then we finish the question, and the question's asking which type of drainage would the nurse document. So it really has nothing to do with it being a pressure ulcer. So sometimes these questions can throw me off personally because I'll start kind of thinking, okay, what do I know about pressure ulcers? But it's good to just kind of read through the question and see what it's asking because it might have nothing to even do with that, and you might be able to answer it. So we have which type of drainage? This would be serosanguinous. So the nurse notes that the wound bed's pink with pink to red drainage. So pink to red drainage is serosanguinous because it's going to have that serous and the sanguinous. So it's going to be a mixture of light red, blood-tinged discharge. Sanguinous would be bloody discharge, so it would just be red drainage. Purulent would be pussy discharge, so maybe like yellow or green or pus. And then serous is going to be usually straw colored. So in one of the other questions, it said there was straw colored discharge coming out. That would be serous fluid. Number 10, a client has a wound that has been allowed to heal through secondary intention due to excessive loss of tissue. What would be an anticipated assessment finding as the wound begins to heal? A, evidence of edema, infection, or foreign matter. B, small pearl-like or pink areas beginning to appear. C, epithelial and dermal cells forming new skin. And D, platelets and fibroblasts migrating to the wound. So with this question, it's asking about the wound healing. There's 3 types of wound healing: primary, secondary, intention, and then tertiary. So with secondary intention, that means that it's going to be closing on its own and then start to close on its own, and then sometimes they can like suture it up. But this is one where it starts open and it has to kind of heal by itself. So with this, we're going to have granulation tissue. So we'll have B, small pearl-like or pink areas beginning to appear. So we have As you can see here, the wound is gaping and irregular. It's not able to be stitched up. If it's secondary intention, there is no closing of the skin. So then granulation tissue will appear, that red, beefy tissue. So you ever hear like pearl-like or red and beefy, those are like keywords that it's granulation tissue. And then the epithelium will fill in the scar. And sometimes they'll close like the wound after it's already started healing, then they'll close it, and that can still be secondary intention. Yeah, I'm pretty sure. Okay, that's tertiary intention. So with the secondary intention, it just has to close on its own. So for number 11, a nurse educator is reviewing the wound healing process with a group of nurses. The nurse educator should include in the information which of the following alterations for wound healing by secondary intention. Select all that apply. A stage 3 pressure injury, B, a sutured surgical fracture, C, casted bone fracture, D, laceration sealed with adhesive, and E, open burn area. So this one's just asking which of the following wounds would heal by secondary intention. So the answer is going to be A and E. So secondary intention, like we said, is going to have to heal on its own without any intervention. So a stage 3 pressure injury, there's not much we can do to help pressure injuries, and we never close them up. They just have to heal on their own. So that would be secondary intention. B, a sutured surgical fracture. This would be primary intention. It's sutured. Immediately we know primary. A casted bone fracture, again, that would be primary. D, a laceration sealed with adhesive. Again, it's going to be primary or possibly maybe tertiary if it had some time to heal first. But again, if it's able to be closed up, it's not going to be secondary. And then E, an open burn area. A burn we wouldn't be able to like suture closed or anything, so that would also be healed through secondary intention. So with secondary intention, there's extensive tissue loss that prevents the wound edges from being approximated, and they should not be closed. So that's kind of how we can remember that one. With tertiary intention, a lot of times it'll be a wound that's not sutured and left open. They'll pack the wound, and then after the wound has had time to heal on its own a little bit, then they'll suture it closed once it's like nice and clean and healed. So that can be kind of like why you might use tertiary intention. So make sure you know those 3 definitions. This is a really good like visual of that. Number 12. Which information should the nurse include when documenting the characteristics of a pressure wound located on the hip of a client? A, the location of the wound. B, the length, width, and depth. C, nutritional status of the client. D, presence of undermining or tunneling. And E, number and type of dressing supplies used. I'm just going to grab something real quick. All right, so for this one, when we're documenting, we want to always be factual and as specific as we can. So we would want to document the location of the wound, very important. You want to note the length, width, and depth. So you guys probably did this in lab where you had to measure it, and you'll use that like little stick thing that goes down to measure how deep it is. The nutritional status of the client, that's not going to be a characteristic of the wound. D, the presence of undermining and tunneling. Yes, definitely. These pressure injuries the tunneling is kind of like when it goes like out to the side and you might not know, but you're able to kind of stick something in there and see, okay, it's actually going underneath the skin over to the right, you know? So that kind of shows how severe it might be. And then we would not document the type of dressing supplies used when we're documenting like the characteristics, but it's really important that we document the location, the length, width, depth, and undermining or tunneling. And you'll notice with documentation that not all nurses do it, you know, the same, and they don't all do it the right way. So you might get in and have a client that has a pressure wound, and it might say that the wound is 2 centimeters, and you might think, oh, I'm not gonna, measure it. They measured it last night. Well, then you're like, well, maybe I should. So you go to measure it, and it's 5 centimeters. So, say that the doctor had called you that day and you said, oh, it's 2 centimeters. That's what the nurse last night said. It's like, it's really important that, you do it every single time, that because you don't always know that the person before you actually didn't copy the person before them and the person before them. And then, when was the last time someone really did it? So super important to always be keeping up to date with those wounds and doing it yourself. It doesn't take very long to just check those things and to document them. If it wasn't documented, it wasn't done, and in 10 years, if you have to go to court for it, you're not going to remember the length, the width, and the depth, right? So, number 13. Which client is at high risk for wound dehiscence? So, good one. A 55-year-old obese female who underwent an abdominal hysterectomy. B, a 75-year-old thin male who underwent a total hip replacement after a fall. C, a 20-year-old thin female who underwent an emergency appendectomy. And D, a 40-year-old obese male who underwent back surgery for a herniated disc. So these questions where they give you the case scenarios, these can be really tricky. These are ones that make me kind of feel like, oh no, this one's going to be hard. So for these, what I really like to look at is it's asking me who's at the highest risk. So I'm looking for which risk factors in here that I'm seeing that are risks for wound dehiscence. So you could even circle those. Obviously, we don't have paper, but kind of like circle them in your head. Okay, what are risk factors for wound dehiscence? And then we'll look at whose risks are the worst. So let's go ahead. So the answer for this one's going to be A, the 55-year-old obese woman who underwent an abdominal hysterectomy. So the reason for this is because we see two key features of risks that are for wound dehiscence, and that's being obese and having abdominal surgery. Those are two of the greatest risk factors for dehiscence, and the reason is it makes sense. So if you're obese, your body is going to kind of be, you're laying there, it's going to kind of like pull apart, right? Because you have a lot of weight and just a lot of extra skin, everything. So they're at great risk for having that dehiscence. And then also having abdominal surgery, because with your abdomen, you're going to be able to increase the pressure in your abdomen by sneezing or coughing or like laughing, or even just like, bending forwards. Your abdomen can easily just pop open, whereas maybe on your arm, you're not having that same amount of pressure that can build up in that space. And same with obesity. The more, bigger your arm is, the more likely it might be to kind of rip apart, especially, and we're talking like patients that are obese, not necessarily overweight. So we also have a 40-year-old obese male who underwent back surgery, but back surgery versus the abdominal surgery, we're going to pick the abdominal surgery. A thin female underwent an appendectomy. She's thin, she's young, and she had probably a small incision for that. So that one maybe, but probably not. And then a 75-year-old thin male, again, we're looking for a patient that's overweight, and he underwent a total hip replacement. So again, the location of that. So kind of look for the overweight and abdominal surgery. Those are two big risk factors. And then also anything like sneezing, coughing, laughing, jerking movement, that would pop that incision open. But it's pretty much always in the abdomen for the most part. Number 14. The nurse plans to teach the nursing student how to perform a focused skin assessment on a patient. Which scale will the nurse likely utilize? A, the push tool, B, the Braden scale, C, the Morse scale, and D, the Payne scale. So when we're doing a focused skin assessment, this is super important. We always want to assess the skin of our patients. And I'll admit, when I first started, taking fundamentals, I was like, oh, my nurse at clinical never checks the skin, but Dr. All, who I had, reminded me how important it is to check your patient's skin, because you don't know that the nurse before you checked their skin, and things can develop really, really quickly. And also every single day, at least at the hospital that I have clinical at, they have to do the Braden scale. So every day we have to do the Braden scale on every single patient that you have, because that's just a part of the assessment. So you need to be doing that yourself, which means you need to be looking at the skin, not just documenting, oh, I didn't see anything. Well, did you look at their back? So with the Braden scale, this is going to go over kind of like sensitivity, mobility, and you'll kind of fill out in each thing what that patient can do. It'll give you a score. I think it's 18 is like the score range. And then depending on that, that'll tell you what risk that patient's at for getting a pressure injury. So the Braden scale is super important. There's also, I think, the Norton scale that can be used, but the Braden scale, that's what we used at my hospital. And it's really common. So the push tool, that's for assessing pressure ulcer healing. So it's not that. The Morse scale is the Morse fall scale. This is another one that you'll do on most of your patients every day to determine their fall risk. And then the pain scale, again, you do that, every day. And that's obviously just going to determine their pain. So really important, that Braden scale. I'm not sure if this is going to be specifically on your test. When I took this class, we did have to know like the components of the scale and the scoring. So I didn't include that in this PowerPoint, but if that does end up on your blueprint, we can kind of revisit that later on, because it is a little different than some of the other scales with what you're scoring. So number 15, the nurse is caring for a client who is in the alarm stage of a stress response. Which clinical finding corresponds to the production of aldosterone, antidiuretic hormone, and renin? A, hyperglycemia, B, decreased peristalsis, C, increased tidal volume, and D, decreased urine output. So with the stress response, we're talking kind of like that fight or flight stage. So the production of aldosterone, ADH, and renin. So immediately my brain thinks of the RAAS syndrome, the RAS system, which is that whole kidney system that has to do with managing your sodium and your water intake. So immediately I'm kind of thinking about that. And so the answer for this is going to be D, decreased urine output. So when you're in the alarm stage of stress, you're going to have decreased urine output because your body is saying, no, we don't have time to pee. There is an emergency. We're in a state of emergency, and that alarm stage is when your body is kind of starting to, your blood pressure is going to increase, your heart rate's going to increase. So yeah, so for hyperglycemia, this will occur, but it's not due to the RAS system. It's going to be because the liver's converting more glycogen to glucose to give you more energy. So decreased peristalsis, this also will occur in the alarm stage, but it's because there's a need for more glucose, not from the RAS system. And then C, there will be an increased tidal volume, but again, it's unrelated to the RAS system. So when we're thinking aldosterone, ADH, renin, immediately we're kind of thinking that urinary tract. So decreased urine output. And for this one, you can also always think like when you're in that alarm stage of a stress response, that is, you just saw a snake and it's about to like slither over to you, like you are at your peak stress level. So you're definitely not going to be, your body's not going to be making urine. It's not going to be, having peristalsis. It's going to be in that fight or flight. Which stage of the general adaptation syndrome would a client be in if they are experiencing tachycardia, tachypnea, and hypertension? A, recovery, B, adaptive, C, alarm, and D, resistance. So general adaptation syndrome is kind of like that flight or flight response. It's one of the like theories that goes with that. So for this stage, it's going to be C, alarm. So when we're having tachycardia, tachypnea, hypertension, those are all increased vital signs. And so when we're in that alarm stage, our vital signs are going to increase because we want to stay alive. We are having that surge of adrenaline and we are ready to, fight off whatever we need to. So this is a great visual of the stages of GAS, or general adaptation syndrome. So first you have your alarm stage where you're like, oh my God, that's going to be where you're releasing that cortisol, epinephrine, norepinephrine, your sympathetic nervous system stimulated. Then we'll move on to that resistance stage. So this is where your parasympathetic nervous system's coming in to kind of try and balance out that sympathetic activity. Your body's trying to like resist that stress response. And then there's a few different ways you can see here. You can go to exhaustion or you can go to adaptation. And this is really important when we get into stress and a little bit later in this slideshow, because there's something known as allostatic load, which is when you are unable to respond to the stressors in your life. You're unable to adapt to them. And if you're unable to adapt after this resistance phase, you end up in exhaustion, which is where your energy is depleted. You can't really, recover. And a lot of times people will end in this stage, and this is where you end up developing secondary like diseases and stuff because of stress. So that's really hard. And then if you are able to adapt, then you go ahead and you go down to the adaptation where you learn to adapt to the stressor, and then you recover. So with this one, say it could be a job. So you got a new job, it's really hard, it's really stressful, you're having that alarm reaction, then you're kind of resisting, your body's like, okay, like, let's see how we can get through this, let's see what we can do to cope. And whether or not you cope is going to determine if you end up in that exhaustion stage or that adaptation and recovery stage. Number 17, the nurse recognizes that a coworker has been working extra shifts and has had several clients die recently. The coworker has made several mistakes when administering medications and is fatigued, forgetful, and preoccupied. What should the nurse do to help prevent burnout in this coworker? A, be proactive about the things you can change and accept the things that you cannot change. B, offer support to help with tasks or with their feelings and suggest speaking with a supervisor. C, join and support professional organizations that address workplace issues. And D, seek help from others. So as we all know, burnout is when you're kind of feeling like you just don't want to do it anymore. You're feeling like you have put in so much work, it's kind of not worth it, and you're just feeling really overwhelmed and kind of beat. And so with this situation, we want to offer support, offer to help them with extra tasks, or like I suggest speaking with a supervisor, maybe taking some time off, maybe just having a different patient load. Sometimes, if like this coworker says she's had several clients die recently, sometimes you can kind of get stuck with, a lot of patients that have similar diagnoses, and sometimes that can become really challenging if you're dealing with that every day. So then you can kind of talk to the supervisor, see if maybe you could get a different assignment for a few days that is a little bit lighter or just different. So the other options are really good suggestions, but they're more of things that should be suggested to the coworker to do. But what can you do as the peer? You can offer that support. And that's really important in the workplace, is to support our coworkers, especially in nursing. Number 18, a client who experienced a traumatic sexual assault is experiencing feelings of guilt, embarrassment, and self-blame. What nursing actions would be appropriate for this client? Select all that apply. A, establish trust and rapport. B, provide strict confidentiality. Sorry, that's a typo. C, encourage verbalization. D, do not use judgmental language or tone. And E, leave them alone to process the details of the event. So this one, the answer is going to be A, B, C, and D. So when we have a client who has experienced a trauma, the first thing that we do is establish trust and rapport with that client. That's always going to be that number one stage. This is kind of that pre-orientation phase, like we talked about previously. We have the pre-orientation, the working phase. That is what that is, establishing that rapport, establishing those boundaries with your patient. You want to always let them know that everything that they say here is confidential. You know, nothing is going to be shared out of this room unless it's an, you know, emergency. But everything that is said here is confidential. The parents don't know, you know, the loved ones don't know. Everything is confidential, and not everyone knows that. You know, we all know, oh, well, HIPAA, but a lot of patients, you tell them, okay, well, this is actually, you know, I could lose my job if I told somebody what you're telling me here, and they're like, oh, really? And they can find a lot of relief in that. So very important to just let them know that they have that right to confidentiality. Encourage them to verbalize. So asking open-ended questions, you know, encouraging them, you know, I'm here to listen. I'll stay and sit with you however long you'd like. And then also always to not use a judgmental language or tone. You want to kind of just keep clear, direct speech, and not use like too much emotion or too little emotion. Just kind of a baseline calm demeanor. And that is really helpful with patients that are going through a period of trauma. And then with E is not correct because we never want to leave them alone to process the details of the event, because this is when they might have feelings of fear and hopelessness and distrust, and they it could maybe either make them feel worse and not really know like how to deal with those feelings, but this can also be kind of a risk for self-harm or for suicide if we're leaving them alone so close to knowing, or right after talking about all of those things, all those feelings are still there. We want to stay with the client to make sure that those feelings don't turn into anything else that could be dangerous. So a client was brought into the emergency department and was the victim of a robbery. Upon assessment, his heart rate is 112, respiration's 34 and deep, and he's complaining of nausea and lower abdominal pain. What is causing this reaction? A, stimulation of the sympathetic nervous system. B, parasympathetic activity. C, hormone level dropping. And D, depletion of energy. So for this one, the answer is going to be A, his sympathetic nervous system is stimulated. So he is in that alert stage of the general adaptation syndrome. If we go back, he is in that, or excuse me, alarm stage of that general adaptation syndrome with this. And we know that because he has that heart rate of 112, we know normal 60 to 100, so he's having some tachycardia. His respirations are 34 and deep. We know normal 12 to 20, so he's having some tachypnea. And then he's complaining of nausea and lower abdominal pain, which we all know when we get stressed out, it's like, oh, all of a sudden I have a stomach ache because you're having that stress response. So it's going to be the sympathetic nervous system. If you have a little bit of trouble differentiating between the sympathetic and the parasympathetic, a good way to remember it is like sympathetic is flight or flight, and then parasympathetic has that, you know, whatchamacallit, whatever that's called at the beginning of the word, in front of it. And this is where your body is resting and digesting. So I always think rest and digest, this is when your body's recuperating. And so you're going to have, you know, lower heart rate, lower respiration. So it's the opposite of that sympathetic nervous system. It's the other, you know, balance. It's the balancing act. So number 20, a client begins experiencing chest pain on and off for a few days and continues to work without seeking medical attention. Which response to stress is this client demonstrating? A, altering the stressor. B, avoiding the stressor. C, analyzing the stressor. And D, adapting to the stressor. So for this one, a client is having chest pain and they're not going to see medical attention. So this would be avoiding the stressor. They know that there's an issue, they're identifying there's an issue, and then they're choosing to ignore the issue. So altering the stressor would be changing their behavior in response so that the stressor hopefully does not cause them stress. Analyzing the stressor would be questioning it, questioning its causes, and then adapting to the stressor would be if the client begins experiencing chest pain, they're able to deep breathe through it. They've adapted to it. They're able to cope through it. They've developed those coping skills to manage it. And this again goes back to that stress and that allostatic load, where if you have these techniques of coping where you avoid the stressor, you can develop diseases like cardiovascular disease. You're more at risk for diabetes because your body has an increased amount of cortisol and those stress hormones because you're not adapting to the stressor. All right, so match the stage of general adaptation syndrome with the appropriate description. So they have the 4 stages, which are alarm, resistance, exhaustion, and recovery. And then we have the 4 definitions that go with it. So let's take a look at the correct answer. So here's the 4 stages in order, and here's the diagram again. So with the alarm stage, that will come first, and that is when the sympathetic nervous system is being stimulated in that flight or fight response. Then we have the resistance phase, which is where parasympathetic activity is going to balance that sympathetic activity. Then we have the exhaustion phase, which is where alarm reaction recurs or continues until energy is depleted. And then we have the recovery stage, which is where you're able to adapt to that stressor. And recovery is what we want to happen when we have a stressor. So a nurse is caring for a client who has pancreatic cancer that is unresponsive to treatment. The client is experiencing significant weight loss and fatigue, but when the nurse asks how they're feeling, they respond with, "Great, I'm going to beat this cancer." Which of the following defense mechanisms is the client using? A, regression, B, projection, C, repression, or D, denial? So the defense mechanisms are what we use to kind of deal with stress in our life. So this defense mechanism is going to be denial. So they're having these issues and they're saying, "Oh no, everything's fine, like no worries." So that's denial. They're not accepting what the reality of the situation is. So regression, this is really common in children a lot of times. So regression is when you're going to lose skills that you already had, or when you're stressed. So with children, a lot of times you'll see if they're say around like 3 years old and they have like a sibling, they'll all of a sudden regress and like not be potty trained anymore, or not be able to like sleep in their bed anymore. So they're kind of regressing as that stressor, kind of acting more childlike. Projection would be, you're feeling one way and then you're going to kind of project those emotions onto another and be like, "Well, I'm really mad." So I'm going to be like, "Well, this person has just been so mad and they just have so much anger." But in reality, I'm talking about myself. I'm just projecting what I'm feeling onto someone else's situation. And then repression is going to be kind of pushing down those feelings and repressing those emotions. So someone's like, "How are you feeling?" Like, "Oh, I'm feeling fine. Like, I don't really have any emotions about it." So they're like repressing those feelings rather than dealing with them, which of course isn't good. You want to kind of confront your feelings. Number 23. A nurse is caring for a client who's delivered a healthy newborn. The client is tense, refuses to hold the baby, and tells the nurse, "I have no idea how to handle having a baby. I wish this pregnancy had never happened." Which of the following statements should the nurse make? A, becoming a parent is a new experience for you. Let's talk about your concerns. B, you should be thrilled about having a healthy newborn. I would be. C, why don't you hold the baby? I'm sure it will make you feel better. Or D, how can you think that way? This is a joyous occasion and should be celebrated. So these ones always come up on the exams. The answer is going to be A. Becoming a parent is a new experience for you. Let's talk about your concerns. So let's talk about your concerns is always going to be a key phrase of what the answer is going to be. That's a great phrase. You'll kind of memorize what those phrases are in regards to kind of therapeutic communication. There's just these key things that are just always like safe bets to say, and this is one. Let's talk about your concerns. So someone's kind of giving you you're kind of thinking, this is concerning me. I don't really know what to say. So a great thing to say would be, let's talk about your concerns. Like let's dive deeper into this. And this is kind of like an open-ended response, so where you can kind of hear more about what the client's thinking. But becoming a new parent is a new experience for you. So this is validating how they're feeling. She's saying, I have no idea how to handle having a baby. So you're kind of restating how she's feeling, kind of validating those feelings. So she's kind of stating, being a new parent is hard. And so restating kind of what they're feeling is always a really good skill for therapeutic communication. And super important, an individual's perceptions of and responses to the stressor determines whether the stressor is positive or negative. So positive stressors are eustress, negative stressors are distress. So when we use our therapeutic communication skills, we can create like a safe environment for them to express those feelings, and then hopefully that stressor can turn into a positive stressor. So hopefully by saying this to the mom, we're able to hear her concerns, teach her what skills she needs, some coping skills, some education about, being a new mom, and then she's able to have a positive experience. Now, if we said, you should be thrilled about having a newborn baby, I would be. Now this mom is feeling really guilty, feeling like her feelings are feeling invalidated. And then this stressor of having a new baby might turn into distress. So super important. So A would be our best response for this. C, you see why, automatically no. We never ask them why unless they refuse a medication. It's the only time. B, no, we would never say never give your opinion, never give advice. It's not your business. You're just the nurse, you're not their friend. How can you think this way? This is a joyous occasion and should be celebrated. Again, no, should not say it. If it sounds like something that like you would hear and think, ooh, like if you heard the mom say that and you kind of get that face, I wouldn't have said that. That's kind of how I feel about these three responses. Just really not the best and not appropriate for the nurse-client relationship. A nurse is caring for a college student admitted for acute intoxication. The client reports feeling overwhelmed and expresses an inability to cope with stressors at school. Which of the following statements should the nurse make? A, drinking too much alcohol is not the best choice. I suggest you stop drinking. B, I can see why you're using alcohol to cope. You've got a lot going on. C, let's talk about the coping methods that have worked for you in the past. And D, I've been stressed before too, but I tell myself that I can handle it. So for this one, the answer is going to be C. So this is another response you'll see a lot with therapeutic communication, is going to be talking about those coping methods that have worked for you in the past. So we see he's here for acute intoxication. He's obviously coping by using drugs and alcohol, which is not a good way to cope. So let's talk about ways that you've coped in the past that haven't been drugs or alcohol. And this kind of opens that branch to not only reminding the client that they are able to cope without those substances, and it also brings up a good conversation for discussing some new coping methods and teaching them some new skills. So drinking too much alcohol is never the best choice. I suggest you stop drinking. No, that's not a good one, because you're just kind of giving it's a little bit opinionated. A, I can see why you're using alcohol to cope. You've got a lot going on. B, that's kind of that's validating that he's using alcohol, so that's absolutely not the right answer. D, I've been stressed before too. Nope. You kind of want to not pick the ones that have an I in them. That would not be a good one. I tell myself I can handle it. That's not therapeutic. We're just saying, oh, you're not able to handle it. You need alcohol. That stinks. So that's not therapeutic. Our goal is to build that relationship, the trusting relationship with the patient, ask open-ended questions, and be able to work with them together. So by saying, let's talk about the coping methods, you're showing them you're interested in hearing what they have to say, you're establishing that relationship with them, and you're looking for kind of some more information on what might be helpful to them. So our last question here, a nurse is caring for a client who reports experiencing stress over an upcoming surgical procedure. Which of the following statements describes the characteristics of stress? A, stress is an easily defined phenomenon regardless of viewpoint and discipline. B, stress is a condition in which the body responds to physical, emotional, or environmental changes affecting one's state of equilibrium. C, stress only affects the individual and does not affect the person's family, friends, or other associates. D, the lack of definition regarding stress does not pose a problem for the client or the nurse. So this one's like a definition question, so the answer is going to be B. So what is stress? So stress is when the body is responding to those changes that are, different. So this can be physical, emotional, environmental, mental, and they can be positive or negative. We a lot of times think of stress as being a negative thing, but it also can be a positive thing. When you think about school stress, definitely can be negative, but it can also be that perfect amount of stress to keep us motivated and, working hard. So A is just not a great definition, and I wouldn't say it's maybe easily defined. There is a definition regarding stress, so D is not the correct answer for that. And then stress does affect the person's family, friends, and associates a lot of the time. That can be even the reason that the patient finally seeks help, is because their family and friends and associates are saying, enough's enough, your stress is starting to cause problems in my life, and I'm really seeing that stress affect you, and it's so definitely C's incorrect. So B is going to be our best answer for that one. All right, I'm going to end the recording here, and good luck on this content, everybody. Let's see.